Good afternoon, everyone. I'm Melanie Quintana, a statistical scientist at Berry Consultants. Today in this webinar, I want to talk about disease progression modeling and how it can be used to make better, more informed, and more powerful clinical trials in rare disease. I want to start by giving two motivating examples in very different types of diseases for using disease progression models. So the first is in Alzheimer's. More specifically, a very rare genetic form of Alzheimer's that occurs in less than 1% of the total Alzheimer's population. If you have this genetic mutation, you will absolutely develop Alzheimer's, and likely at a very early age of onset, so between 30 to 50 years old. You'll likely develop it when your parent who had the same mutation developed Alzheimer's. And the goal here in this project was to develop a clinical trial to answer the question if we have a treatment that can modify disease progression or slow cognitive progression. And the issue in Alzheimer's in general is that although lots of resources have been put forth to try to find a treatment that can modify disease progression in Alzheimer's, we don't have any current treatments that are known to slow or modify the progression. And there's been many failed trials in this area. It's now that we look back, we think it's likely because we're enrolling subjects who are highly demented and highly progressed in terms of where they are in the disease, and the treatments aren't able to act in the way that they should on these subjects who are too far gone. So now the goal really is to enroll subjects in clinical trials who are preclinical or almost asymptomatic in terms of cognitive function when we think that the treatments can really have an effect on this disease. Of course, the issue then becomes, do we actually know that a subject would likely progress under natural progression over the course of the trial? The reason the original trials were run on the subjects more severely progressed is because it was thought that this subset would be a more homogeneous subset in terms of cognitive progression. Another very different disease, but also a genetic progressive rare disease, is called GNE myopathy. GNE myopathy is categorized by a slowly progressive muscle weakness and atrophy, and it affects different muscles at different stages of the disease. Subjects often are diagnosed with the disease by actually starting to trip when they walk. So it starts sort of in the the ankles and works its way up. So because of the lack of muscle tone in the ankles and being able to flex the foot, patients start to trip over themselves. You can see here in the MRIs that slow sort of muscle deterioration starts in the ankles, moves up sort of to the hamstrings and the quadriceps, and then in late stages, almost all the muscles are gone in the lower extremities, and the upper extremities are the ones who are actively progressing. So again, the goal with this project in GNE myopathy is to create a clinical trial in which we can test if a treatment slows the rate of decline in muscle strength. And the issue with GNE myopathy is that the subjects, given the disease stage, you may be actively progressing on a very different muscle group. So although these two diseases are very different in terms of how they progress and there are different clinical endpoints that are important in them, there are some commonalities. So the commonality in the complexity in these diseases is that there's a huge heterogeneity in progression in terms of how a subject will progress, when they will progress, how quickly they will progress, and what endpoints they will progress on given the stage that they are in the disease. This leads to a large variability in the key clinical endpoints. So we have different muscles in GNE myopathy may be affected at different points in the disease, as mentioned earlier, and this causes a lot of trouble in being able to adequately power different clinical trials. So common solutions, as I alluded to earlier in DIAN, is to enroll a more homogeneous subset. So maybe only enroll subjects who are actively progressing on the key cognitive endpoint that we're looking at. Another common solution would be enroll enough subjects to overcome any heterogeneity that we may see. And of course, both of these solutions are not ideal in the rare disease setting. The first would be making a rare population even more rare by requiring just a very small subset of the patients. And the second, the sample sizes needed to overcome the heterogeneity may just be not feasible whatsoever in terms of the number of subjects that even exist or that we know of. So with that being said, I want to talk about common solutions and the solutions that we have used for rare diseases. And both of these rely on disease progression models. Both in GNE myopathy and in DIAN, we are blessed with very nice observational studies that were being run that provided us with very rich natural history data sets. And we were able to use those natural history data sets to summarize natural progression using disease progression models. The second way that we use disease progression models in both GNE myopathy and DIAN is to actually analyze the data from the clinical trial itself to incorporate a treatment effect parameter and to decide if the treatment is modifying disease progression. Before I go any further, I want to back up a little bit and very clearly define what I mean by a disease progression model. So what I mean here and what I'll mean throughout the course of this talk is that it's a mathematical function, so any sort of function, it could be parametric, non-parametric, smooth or not, that quantitatively captures how a subject will evolve over the course of their disease. And it may do so using a single or multiple disease-specific biomarkers and/or clinical outcome measures. For a progressive disease, this function is likely monotonic, so you start at normal and then slowly progress to worsen over the course of the disease. And ideally, we can model this progression as a function of disease age or stage in the disease. As I alluded to earlier, there are two main uses that I want to talk about today of disease progression models. And I want to differentiate between the two. The first is, and the more commonly used way for disease progression model is through a virtual patient simulator. So what this is we take our natural history data, we create some sort of disease progression model to summarize it, and then we use that model itself to simulate patient-level data from the model. The patient-level data then enters into a prospectively defined clinical trial design, just as a patient would enroll into a trial. And then we can do this thousands of times in clinical trial simulation to understand the power and different operating characteristics of the prospective proposed design. We can then use these virtual patient simulators to make and answer key design clinical trial questions, such as how many subjects do I need, what length of follow-up do I need, how aggressive do I want to be in terms of success roles or futility. Another use of disease progression models that's less common is to actually then use the model itself to analyze the data. So incorporate a treatment effect parameter and understand and help us summarize how that treatment modifies disease progression. So let me go back and give more specific, concrete examples within the DIAN studies and the GNE myopathy studies of how we're using the disease progression models in both of these ways. As I mentioned, in DIAN, we are blessed with very rich natural history data. This is a plot of that data. On the x-axis, we have estimated years to onset. We call this EYO. What this is, as I mentioned before, based on when the parent with the same mutation got Alzheimer's, we can have a priori an estimate of when each of these patients will develop Alzheimer's or have onset. On the y-axis, we have the cognitive composite z-score. So this is any sort of composite where we combine different cognitive tests and how subjects score on those tests. So as this declines, a subject's worsening on their cognitive abilities. The black lines here and black dots are non-carriers. So these are healthy individuals who will not develop dominantly inherited Alzheimer's. And the red lines are mutation carriers, so people who absolutely will develop Alzheimer's. So you can see here a large amount of variability in how subjects score on these cognitive tests at normal. Also some variability in when they will actually develop Alzheimer's in the X space. However, when a subject does start to decline, we notice this sort of steep waterfall effect of how quickly they progress thereafter. So our goal really is then to use a disease progression model to summarize the red data here. In DIAN, we have a non-parametric, monotonically decreasing function to summarize this data. And it's simply just a spline where we estimate the decline in cognitive functioning at each EYO. We then also introduce a subject-level random effect for the true time of onset for each subject. So as I mentioned before, we have an a priori EYO for each subject based on when their parent developed it. And we can have a delta I for each subject, moving them left and right on the x-axis to when the model actually believes was their time of onset. We also have a subject-level random effect for how a subject measures or does on the cognitive scoring at healthy. So some subjects may do better on average on these scores, and some subjects worse. So here again is our natural history data. And on the right, I have plotted the same data where I've subtracted the random effects both in the Y space and the X space. And then we can draw our estimated average decline line using our monotonic spline function here. So now that we're able to summarize decline as a function of EYO, we want to use this model and the summaries of this model and the variability around the estimates to simulate patients. So I want to walk through a set of slides to show exactly how we simulate from this model. So as I mentioned, imagine here the black line is the expected decline as a function of years since onset. And we have variability in the Y space. So some subjects, as I mentioned, do worse on average, some better. We also have variability in the X space. Some subjects will be less time since onset and some more. This subject that we simulate in particular, the first one, it does a little bit worse. So their random effect is negative in the Y space on cognitive measures, and they are 5 years since onset. If they were enrolled as a control subject, we would then expect them to follow this black dotted line. However, this subject is going to be a treated subject, so we'll assume some slowing in that rate of progression, and we expect them to follow the blue line. We can then sample data around that blue line, given our estimates of within subject variability, to get a sampled or simulated cognitive scores at different years since baseline. So this subject scored about -3 on the cognitive composite at baseline, and then remained relatively flat. So got to about, actually increased a little bit to about -2.5, 4 years since baseline. We can continue doing this with another subject, subject 2. This one is a control subject expected to follow this black dotted line, and here is their data in terms of years since baseline. So on and so forth. Then I'm starting to plot the means for the blues, the treated, versus the means for the blacks as a function of years since baseline, their change from baseline. So what you can already start to see separation between the blue and the black groups here, where the blue group tends to decline about -1 unit on this measure, whereas the black group tends to decline about 2 units, so twice as much. So now that we're able to simulate subjects from a realistic model, we want to be able to do this thousands of times to understand power of proposed designs. So imagine one potential proposed design is that we're going to enroll 80 subjects per arm. We're going to randomize 3-to-1 treatment to control. The max length of follow-up is going to be 4 years. And we're going to use a very traditional MMRM analysis method, a method that's used for these types of progressive disease. In doing that, I'm plotting the power given the assumed % reduction in decline under the treatment. And here we can see if we assume a reasonable 40% reduction in decline under this treatment, the power for this proposed study is less than 30%. So great, we did all this complicated work to make realistic virtual patient simulators, and we see that we have a very, very underpowered trial. So this is where the second part and the second use of disease progression models comes in. So it's very well understood that the MMRM itself has issues when analyzing this type of data. So the first issue is that there will be a dilution in any effect that we see difference between treatment and control due to subjects who are enrolled who are not expected to decline. So we go back to our simulations. If we enroll someone over here, under control and treatment, they both will remain flat and there'll be no difference between treatment and control. Also, if we enrolled someone down here where they've stopped their progression very late in the disease, you would expect no difference between treatment and control. And all these subjects will do is dilute any sort of difference of the treatments and controls of the actively progressors. Another issue with the MMRM is that although it does take into consideration all of the longitudinal data to estimate random effects for subjects, it really only looks at the magnitude of the difference between treatments and controls at one specific time point. So it only looks, say, at 4 years. However, if you look back, you can see that we kind of have a consistent difference even at 3.5, 3, and 2.5 years. So it would be great if we had some sort of model that used the earlier time points as well to understand this difference between treatment and control. And that's exactly what this disease progression model can do if we can incorporate a treatment effect parameter into it. So in DIAN, we incorporate this parameter that essentially is the slowing in the rate of progression. So it assumes that there's a proportional treatment effect at each EYL. This is not assuming that everybody will, the magnitude of the difference between treatment and control will be the same at each time point, but that the proportion or the slowing will be the same. So if we enroll someone, say, all the way over here at -15, and they're not expected to decline much, then the difference we don't expect to be that different under a perfect cure and natural progression. Whereas if we enroll someone later on in the disease and say they're expected to decline 1 point, then under a 50% slowing, we would expect them to decline only half of a point. So the magnitude will be much larger there. So this model does two things that we hoped for. It adjusts for the fact that some people are just not expected to decline, and these subjects over here will be weighted less in our analysis, whereas the subjects who are enrolled here and there's expected to be a large difference, they'll be weighted more in the analysis. Another thing it does is it allows us to use all time points, so we can measure the gap that we see here, 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 at all different lengths of follow-up to really estimate this proportional treatment effect. This allows us to handle differential length of follow-up, so it allows us to include subjects who may actually have extended follow-up. So some subjects who are enrolled earlier on in the trial, if we have to wait for everyone to get to 4 years, may actually be followed for 4.5 or 5 years, and we can use that extended follow-up data and gain a lot of power using it. Much like a sort of time to event analysis where the more exposure you have, the more power you have. In just doing this, we're able to take the power that we had using the MMRM analysis from less than 30% to an increase of over 90% power. So one word of caution I would say in creating this analysis model is to make sure that the assumption that we make is true or believable. So if you thought that you had a therapy that had sort of a symptomatic bump or benefit, and then the subjects progressed as control, this would not be a good model to estimate that symptomatic benefit. However, it is believed that most of these therapies would act as sort of a slowing the rate of progression. And so this model and the assumptions it makes are believable in the community. Next, I want to look at the example in GNE myopathy. So GNE myopathy is a good example of a disease progression model using multiple outcome measures, where DIAN was a model with just a single outcome measure. Again, like DIAN, we were blessed with a very nice natural history data set. We had, at the time I made this slide, we had about 38 patients followed anywhere from about 0 to almost 3 years, visits every 3 to 6 months, and several measurements were taken and summarized for this natural history data set. One of them that we'll talk about is the 6-minute walk test, and this is the common endpoint that's used in muscle diseases, and it's essentially how many meters you can walk in 6 minutes. Another endpoint that they capture is the quantitative muscle assessment, or QMA, for different muscle groups. Here's actually a picture of someone doing the QMA. It's a very objective measure that measures the force that you exude on this machine when using a muscle. So for instance here, this subject used about 8 to 7.5 kilograms of force on their dorsiflex, that's their ankle muscle. And we can then take this kilogram measurement and convert it to a percent predicted of what a subject who is healthy, of the same age, gender, and BMI would be expected to perform, how they would perform. And what we can see is this subject already is at about 25% of what a healthy individual could do on this machine, on their dorsiflex. And we can do this for lots of different muscle groups. So you can hear on the top, you can see their left and right grip, which remains relatively normal in terms of what other healthy individuals can do. So first, before we develop and talk about any complicated joint disease progression models, I want to just do some very simple analyses to determine what sample sizes would be needed if we used very simple endpoints and very simple sort of t-tests in the change from baseline of these endpoints after, say, a year or 2 years. Well, the first endpoint that I mentioned is commonly used is the 6-minute walk. And here we have longitudinal data on the 6-minute walk test for multiple subjects in the natural history study. You can see that there's a large variability in how many meters a subject can walk at baseline. So ranging from above 600, almost 700 meters, to less than 200. And then subjects remain relatively flat after that. There's not sort of a steep progression after baseline on this 6-minute walk test. If we then just use basic linear models to estimate how much we think a subject will decline on this endpoint over the course of a year or 2 years, we expect that over a year they will decline about 10 meters. So they can now walk 10 meters less in a year. And the standard deviation around that is about 32. So large variability in this change. And due to that small change with large variability, we would need about 1,200 subjects to have 80% power on a 1-year study. For a 2-year study, this gets reduced to 300, but still these numbers are not feasible whatsoever in this very rare population. Another single endpoint that has been done before is the upper extremity composite. So essentially what this does is looks at the QMA I showed before and sums across all the upper extremity muscles. And this was actually the primary endpoint in a recent phase 3 trial that Ultragenyx did in GNE myopathy. And actually, as this trial was going on, we were able to look at our natural history data, plot it for this particular endpoint, and get the power for that endpoint as well. And what we estimated was for a 1-year study with 80 subjects, which Ultragenyx was enrolling, they would have about 21% power. So we were able to estimate that this study was very underpowered on the proposed primary endpoint. And I think this really highlights how important natural history studies are to run, especially in rare diseases, as well as how important it is to do these sort of analyses to understand the likely rates of progression on the endpoint that you're proposing. Came out in August of 2017 that Ultragenyx was not successful in demonstrating any difference between the treated patients and the control patients on this endpoint. And it's truly unfortunate in that this was a failed trial, that it was completely underpowered, and we will not ever be able to know if this treatment truly does slow the progression of disease here. So now that I've set it up and shown, we're really underpowered with very traditional endpoints, I want to talk about what can we do in this area. And the goal here all along was to develop this joint model to first understand how the different muscles progress as a function of disease stage. So we drew this picture from day one and said we want to be able to recreate this picture to summarize the data to say, when does each muscle start to decline? How quickly does it decline? And sort of what is the overall picture of progression in GNE myopathy over the entire course of the disease. Of course, to be able to do this, we have to be able to know this sort of latent disease age variable, or where a subject is in the disease, and it's not observed. So here is some pictures of the natural history data for 4 different subjects. I have plotted here the muscle strength, or the percent predicted, like I showed you on the previous slide, for 6 key muscles as a function of chronological age. So subject A here, both red and orange are on top of each other, and this is knee flexion, so hamstrings, and ankle dorsiflexion. And this subject at age 30 is completely declined on both. So no muscle strength left on both of those muscles, and is actively declining on grip, shoulder abduction, and elbow flexion. So very actively declining on the upper extremities. Whereas subject B, who is about the same age as subject A, relatively flat on those upper extremities, but actively declining on their ankle dorsiflexion. So you can already see right away that chronological age is not a really good predictor of disease stage. So this subject, we would say, is later progressed or later disease stage than subject B. Another thing you can notice from the natural history data is that the percent predicted at healthy can vary widely between subjects. So this subject D is completely progressed on their ankle dorsiflexion, but at or above 1 for the other muscle groups. So we need to be able to incorporate sort of this subject level random effect like we did in DIAN to estimate at healthy how much stronger you tend to be than the average person. Here I have plotted for all 6 of these muscle groups all of the natural history data, muscle strength as a function of chronological age. And really, if you can't see anything here, that's the point. The only muscle that we can really see progression on is knee flexion. That kind of looks like there's some sort of clear decline as a function of chronological age. But across the board, no clear picture of clinical progression as a function of cognitive age or chronological age. So our first sort of proof of principle exercise was to first create this knee flex-based disease age. So fit some sort of decay or disease progression model to muscle strength in the knee flex. Then move the subjects left and right on this x-axis so that they fit that line very well, and call this the knee flex disease age. This is based on your knee flex score. This is the stage in which we think you are in the disease. Then look at all the other muscles and see if we have a clearer picture of decline. So here again, we have the knee flexion data. We can fit this sort of disease progression model to knee flexion and move all the subjects left and right so they fit that model really well. So D here, since they're up about 1 on knee flexion, they would get moved all the way to the left. We think they're earlier on in the disease. Whereas A, they're completely declined. They would get shifted all the way over to the right, later stage disease. So we use this knee flexion-based disease age and then plot the muscle strength for all of the other muscles that were not included in this model. We can see a clearer picture of decline as a function of where you are on knee flexion. So very sharp sort of decline on grip, shoulder abduction, and elbow flexion. And we see that knee extension remains kind of stable throughout. And this actually had, this was known to the scientists here, that this disease actually was known as the quadriceps sparing disorder. So when we showed them this picture, they said, oh yeah, that makes sense. These people aren't expected to decline on knee extension. So we had some face validity here. So since that worked so well, sort of aligning subjects based on their knee flexion score, we decided to create a disease progression model where we would use all of the muscle scores to estimate disease age, and then simultaneously estimate the overall rates of decline given that latent disease age variable. So here we're going to model, even though this looks quite complex, we're just modeling that proportion of muscle strength at each visit in each muscle for each subject as normal with some mean and some variance. We assume here that the variance is a function of the mean, and that as someone progresses and gets more towards zero, we think the variability will be less on these measures. The mean itself is, we assume, a logit decay function with the following components. So first we have a muscle-specific location parameter. This will say when each muscle is going to start the decline. We have a muscle-specific slope parameter that tells us the rate of decline for each muscle once it started to progress. We have a subject-specific age adjustment parameter. So this is similar to that random subject-level effect in the X space that we saw in DIAN. Now this parameter is going to determine the disease age, so shifting subjects left and right to determine their disease stage. And then we also have a subject-level random effect in the Y space to account for variation in the overall strength of subjects at healthy. So essentially then what we're doing is we're using this joint model to take these snapshots of the disease, small, short snapshots of the disease that are provided by each subject in the natural history data set, put those pieces of the puzzle together, those small snapshots, to then understand the entire course of the disease. So for instance, patient A here maybe is estimated to have a baseline disease age of 15. So let's put them over here in our puzzle. Whereas patients D and B are earlier on, and we move them over here in our puzzle. And of course, in our model, there's variabilities to these disease ages, and we're trying to estimate them as well. So those are in their own right. But once we put everybody on their puzzle piece, or place the puzzle pieces based on disease age, we can then estimate overall expected decline of each of the muscle groups as a function of this latent variable. So here now is a picture of each of the muscle groups relative to that latent disease age variable that's estimated using all of the muscles in our joint model. And we can see several summaries here. The first is, what age do we expect each of these things? So sorry, let me back up 1 second. We anchor this model so that disease age 0 is defined as when knee flexion is 50% of your expected max strength. So then we can say what disease age or how many years earlier and later to each of the muscle groups reach that 50%. So here for ankle dorsiflexion, we think that about 7 years before knee flexion reaches 50%, ankle will reach its 50 percentile. Also, we think when knee flexion is at 50%, ankle dorsiflexion will likely be at 4%, so almost completely declined. Again, we see that knee flexion remains relatively stable and is expected to be about 70% when knee flexion is at 50%. Grip is expected to reach its 50th percentile about 10 years after knee flexion. Shoulder abduction reaches about 2 years. Elbow flexion about 9 years. So then we can put all of these muscles on top of each other and finally able to create the picture that was our goal from the beginning, to see and understand how these muscles decline relative to one another, as well as the variability around those declines. We're also able to take each of the subjects from our natural history study and predict the decline that will occur over the next, say, 10 years. So for instance, as we expected, subject A will be most actively progressing over the next 10 years on their upper extremities. So many of their upper extremities, grip, shoulder abduction, and elbow flexion, will go from, say, above about 25% to less than 10% over the course of the next 10 years. Whereas subject B will be most actively progressing on dorsiflex and knee flexion over the course of the next 10 years. We can then also take this latent disease age that we've estimated for each subject and look at how that relates to functional measures. So the one question that was brought up throughout our modeling was, okay, how does this QMA or muscle strength actually relate to how I feel and different functional measures? So here we have plotted for different activities, such as climbing stairs or walking, the sort of moving average of a subject in the natural history study, how well they do as a function of disease age. So here, for instance, with climbing stairs, even at the beginning, these subjects tend to be slow, intermittent use of the handrails when climbing stairs. They then, around disease age 0, become dependent on a handrail. About disease age 25, they need additional support, and by 35, they're unable to climb the stairs. Similar picture for walking, slower mild unsteadiness until about disease age 0, where we know the knee flexion becomes about 50%, and then they intermittent need for the use of a device. At about disease age 30, they're dependent on a device, and then wheelchair dependent by about 35. Compared to that, the upper extremity tasks tend to be relatively flat over the course of those 40 years. So for instance, dressing oneself, that's done pretty normally up until about disease age 0, and then some increased effort, and then finally sharp decline after that. So if we can put this whole picture together to really summarize the different, how a subject will feel, how they'll measure on QMA, and what activities they'll be able to do at the different disease ages. So you can see those plots here. Compare disease age 0, where essentially we're completely declined on ankle dorsiflexion, the shoulder abduction and the knee flexion at about 50%. So those muscles are starting to decline here at disease age 0. And then as we saw on the previous slide, this corresponds to when we start needing to use a handrail to climb the stairs, some unsteadiness when walking, and also needing to use substitute motions when standing from sitting. Compare that to a disease age 30 subject where they're almost completely declined on their upper extremities and lower extremities. The only real muscle strength they have left is in their knee extension, and this tends to reflect itself as in terms of needing the handrail and additional support when climbing stairs, dependent on a device to walk, and great difficulty turning in bed, and also other fine motor tasks. So now that we are able to really summarize and understand natural progression in terms of all of these, the muscle strength on all of the different muscles, as well as in terms of functional measures, we want to understand how we can incorporate a treatment effect into this model and understand if that treatment modifies disease progression. So just as in the DIAN model, we assume this gamma here, which it is essentially a proportional slowing in the rate of progression. This proportional slowing is assumed to be common across all muscle groups. So we have, you can see all the rates of declines beta K here across all the muscles, but one single gamma parameter. And then we can test if this gamma is less than 1, which would essentially mean slowing in the rate of progression. An alternative way to think about this is a slowing in the number of years it would take to reach a milestone. So if there's a 50% slowing in the rate of decline, and normally it would take you 10 years from where you are to become wheelchair bound, now it will take you 20 years. So you can think of it as a slowing in time as well. And here's just some pictures of what those treatment effects would look like at different stages in the disease or different key muscle groups. So as with DIAN, if you treat somebody or if you're looking at a muscle that's almost completely declined, there's really no hope to discern a difference between treatment and control, even for a treatment that's a total cure at this point. Whereas if you look at a muscle group that's almost actively declining and you treat a subject here, you can see a large difference between where you would be under a complete cure versus natural progression. So this really emphasizes the need to use all muscles when estimating a treatment effect so that we can incorporate those that each subject is actively progressing on. And again, just to ground ourselves and understand, okay, what does a 50% reduction in decline really mean in terms of a treatment effect? Well, for a subject here, this example where a subject is earlier on in the disease, say -8 disease age, this is what their data or their natural progression looks like. And we can then see if from this point, if they were treated here, if there was any slowing or if they were above expected in terms of the rates of progression. This subject, if they were treated or not given any treatment, we would expect them to go to become dependent on a handrail when climbing stairs at 36 years old. So they're currently able to do that with slow intermittent use, but become dependent on the handrail at 36 years old. With a treatment that has a 50% reduction in decline, this would now be 44 years old. So we can see that this subject wouldn't progress on this measure until 4 years later under this treatment. And similarly, with the ability to walk, they wouldn't need to use a device to help them until 48 years old instead of 38 years old. And like we did with DIAN, we can also use our disease progression model to create virtual patient simulators, understand power of proposed designs. So here is one example of a proposed design where we have 50 subjects enrolled, 2-to-1 treatment versus control, and we follow all subjects for 2 years is one set of power numbers. I'm also going to show power for extended follow-up. So this is the subjects who are enrolled at the beginning of the study may be followed for like 2.5 or 3 years, depending on how long it takes for the last subject to enroll to get to 2 years of follow-up. The primary analysis method is that disease modification analysis that I mentioned, and treatment effects are anywhere between 40 to 50% slowing in the rate of progression. So here you can see with a 45% slowing in progression and no loss to follow-up, so no missing data, we have about 80% power under this design. So now you can see the huge increase in power in using this joint analysis method and using the multiple muscles compared to what we showed before, where you would need hundreds of subjects on any single outcome measure. We can also learn things from these simulations, such as what if we had 10% of annual rate loss to follow-up? So what if a lot of people were dropping out of the study? Well, this would take that 80% power and reduce it to about 72%. And instead, what if we have that still 10% annual loss to follow-up, but allowed extended follow-up? So allowed some people to be followed for 2.5 or 3 years. Well, we could gain all that power back, get back to about 82% power. So you can see just with these virtual patient simulators and clinical trial simulations, you can answer a lot of questions that investigators might have in terms of how does power suffer if we have different assumptions. So in summary, I hope that you were able to take away that using these disease progression models plus the use of a clinical trial simulation allowed for more informed decision-making in terms of key questions that you might have in designing these trials. Also, that it's important to consider these progression models as analysis tools, in that we're able to capture multiple aspects and varying stages of the disease instead of just one. And we're able to adjust for expected natural decline versus having to enrich to a more homogeneous subset. And again, I'll end with a word of caution that we need to be working closely with the clinicians throughout the process of creating these models. We as statisticians truly have no problem developing extremely complex models. So we want to make sure that all the inputs and outputs and assumptions that we're making in our modeling are clinically meaningful and are believable. I'll just end with a set of references for the DIAN studies and also the GNE myopathy studies, and thank you all for joining.